Hi all, welcome to Raaonline. Today we are going to deal with various laboratory studies and diagnostic studies which is required in the preoperative period for a patient. Some particular disease might require some laboratory specific testings, but in general we will discuss what are the various tests which you do in the preoperative period. What is the scheme of preoperative testing? The patient is posted for elective surgery. You have a routine preoperative testing or an alternate group of testing, or there is no preoperative testing, and this testing is done because it is going to alter your perioperative management, and ultimately you do this testing to improve the perioperative outcomes. Like that, it avoids the delay in surgery or avoids complication or avoid cancellation in the morning of surgery. It improves the post-operative outcome, post-operative complication. By doing your preoperative testing, you are predicting your post-operative complication so that you will do things to prevent this post-operative complication. Patient-centered satisfaction. You will know that patient is absolutely normal by preoperative testing. That gives a satisfaction of the patient. He is normal except only for surgery. Your resource utilization outcome. By doing your preoperative testing, you can reduce the patient visit and the length of hospital stay, and you can reduce the cost of the overall procedure. And modifying factors of this preoperative testing includes type of surgical procedure. High risk procedure, it is going to modify your preoperative testing. And coming to patient centric factor, what surgery patient is undergoing and what disease is there for the patient, various comorbidities. The other modifying factor is the test which is being done. The test which is done by the treating physician or the treating surgeon or the anesthetist, the time frame in which the test has to be done. A patient is having a coronary artery disease, when you do the viability test, or you are ordering the test ad hoc. Finally, you should not forget the limitation of doing a test unnecessarily, whether it is related to the preoperative testing or associated follow-up procedure. There are also certain limitations with preoperative testing. So, what is the main goal of preoperative testing? It is to deliver cost-effective health care to surgical patient and to screen the patient for disease and evaluate whether the patient is fit to undergo the surgery safely. But at the same time, routine preoperative testing in an asymptomatic healthy patient has poor diagnostic yield. The patient is absolutely normal, asymptomatic. In those cases, if you do a routine preoperative testing, it provides little or no prognostic inflammation and it does not have any beneficial effects on outcome. What are the limitations of preoperative testing? Unnecessary testing may be expensive and leads to costly evaluation of borderline or false positive test abnormalities. Apart from operating room delays and cancellation, this follow-up test may possess risk to the patient that are attributable to follow-up test and associated intervention. You do an unnecessary investigation that might lead to some unnecessary intervention and that might cause delay or cancellation. I will say in most of the hospital, surgeon and the primary care physician order the investigation. They may order the investigation speculating that anesthesiologist will require them for surgery. So, it is the anesthesiologist perspective which is put into the surgeon or primary physician, and they think that anesthesiologist might require this test and they do the test without any diagnostic focus. They don't think on the disease aspect of testing, but they think that anesthesiologists require the test for anesthetizing the patient. Another important goal is you should target which test is required in appropriate patient. By targeting this testing to the appropriate patient, you have both clinical and economic benefit. And this testing can be selective or non-selective. Non-selective is you have a routine screening. For example, when disease comes, you will routinely do all the screening tests for that particular disease. And you have an establishment of a diagnostic baseline. For example, your patient has a diabetes and you establish a baseline sugar. So that baseline is in comparison for what you do in the perioperative period. Personal habit of that treating physician, standard checklist for all patients, physician reassurance, and another important thing for doing all the pre-op routine testing is a medico-legal necessity that not to miss anything. This type of practice has led to plethora of pre-operative testing practice that are costly, highly variable across hospital, and most importantly, it is unrelated to patient perioperative risk profile. Now coming to selective testing. You do only that particular test which is required for that patient. This depends upon patient medical history, planned surgery, and the expected degree of intraoperative blood loss. Here you detect the specific clinical indication that increases the perioperative risk. For example, the patient has undergone a coronary angiography with a dye injection. Here you do a renal function test anticipating acute kidney injury. So you have a specific indication to do a blood test here. So you detect that specific clinical indication that increases the perioperative risk. Shift in strategy from non-selective to selective preoperative testing in low-risk surgical procedure can reduce the cost, but at the same time, patient safety is preserved. As experts in perioperative medicine, anesthesiologists are in a unique position to appropriately select the test which is required for that particular patient. Anesthesiologists led preoperative testing have resulted in more selective ordering of laboratory tests than led by surgeon or primary care physician. So, anesthesiologist has to see the patient first and tell what test is required or no testing is required. Educating and providing specific guidance to surgeon or other primary physician on appropriate ordering tests, anesthesiologists can expedite patient care, reduce cost, and improve the delivery of perioperative medicine. Few guidelines are there for preoperative testing. Most notables are the NICE guidelines and Ontario preoperative testing grid. The NICE guidelines consider both patient preoperative medical status and the extensiveness, invasiveness of the planned surgery, whether preoperative testing is needed or not. So, the surgical procedure are graded as minor, which is like a skin lesion excision, intermediate risk, which includes inguinal hernia repair, varicose vein excision, tonsillectomy or knee arthroscopy, major procedures like total abdominal hysterectomy, TURP, lumbar spine discectomy, thyroidectomy, total joint replacement, lung operation, colon resection or radical neck dissection. 2012 ASA Practice Advisory for Pre-op Evaluation does recommend against routine preoperative testing. It does not recommend routine preoperative testing, but does not make recommendation about which test is required for specific clinical condition. Here, they don't recommend preoperative testing, but also didn't make any specific recommendation which test to be ordered for specific clinical condition. Practice advisory states that the indication of testing should be based on the information obtained from patient record, patient interview, physical examination, and the type of invasiveness of the planned procedure. Patient related and surgery related factor should be considered when deciding whether to order a specific laboratory test. So, patient related and surgical related factor should be considered when you order a particular test. Conversely, the updated 2018 European Society guidelines do make, the ASA does not recommend, but here they make specific recommendation when preoperative testing should be performed. Now coming to a overall laboratory testings which is required for particular disorder. The usual laboratory testing includes electrocardiogram, chest X-ray, complete blood count, electrolyte, creatinine, blood glucose, coagulation testing, liver function test, your drug level if patient is on any particular drug, and calcium level. In cardiac disease, particularly with an ischemic heart disease, you require definitely an electrocardiogram, complete blood count, particularly hemoglobin is very important. If patient is on any medication which can cause electrolyte disturbances, electrolyte is very important. In case of heart failure, ECG is very important. Chest X-ray plus or minus because the patient might have cardiomegaly. In hypertension, the patient might require an ECG and patient might on multiple drugs which can affect the electrolyte balance. So, you have to do the electrolyte level, and patients are prone for kidney disease, you do a creatinine level also. In chronic atrial fibrillation, to assess the rhythm, you need the ECG and drug level. Patient is on digoxin or something for atrial fibrillation, you should assess the drug level for that particular drug. Coming to peripheral artery disease, you require an ECG, and if patient is on any antiplatelet or any other anticoagulation medication, you need a coagulation testing. Coming to valvular heart disease, ECG is required, chest X-ray depending upon heart is enlarged or not, and if patient is on anticoagulation medication, your coagulation testing also may be required. Coming to pulmonary disease, in COPD, you need ECG, right heart failure can be there, X-ray plus or minus, and a complete blood count, particularly hemoglobin status, and patient might be on some drugs which requires a drug level assessment. Asthma, unless it is an acute exacerbation or patient is severely asthmatic, none of the tests might be the same test which you do for chronic COPD can be repeated here. Coming to diabetes mellitus, the patients are prone for heart disease, ECG is a must. Electrolytes is very important here. The patient might have systemic disease which can alter your electrolyte imbalance. The patient are prone for kidney disease, creatinine should be there, and blood glucose and HbA1c should be done in the case of diabetes mellitus. Coming to liver disease, most of the time it can be an infectious cause, alcohol, drug induced or tumor infiltration. Here LFT and coagulation testing will be very important. The coagulation will be altered very much, so all the coagulation tests should be done. Coming to renal disease, you need a complete blood count, electrolyte which will be altered severely in renal failure, and creatinine level should be done. Hematological, most important test is the complete blood count. Coagulation testing can be done to assess the cause if some factor can lead to bleeding. Coagulopathy, again complete blood count and coagulation testing. Coming to CNS disorder, you have to do an ECG, complete blood count, electrolyte, blood glucose which might affect the outcome and cerebrovascular disorder, and your drug level. Seizure, again all the same thing, ECG, complete blood count, electrolyte, glucose and drug level. In tumor, you need ECG and complete blood count. In CNS disorder also you have to go for a vascular imaging of the brain. In vascular aneurysm, ECG and complete blood count. Coming to some other specific condition, malignancy, you need a complete blood count. Hyperthyroidism, you need ECG, complete blood count, electrolyte and your calcium level. Hypothyroidism, it is similar except that calcium may not be required. Cushing disease, you need complete blood count, electrolyte, glucose. They are prone for diabetes mellitus. So, you have to do a blood sugar. Addison disease, it is a reverse of Cushing. Again, you have to do a complete blood count, electrolytes and glucose level. Hyperparathyroidism, you need ECG, complete blood count, electrolyte and the calcium level. Hypoparathyroidism, ECG, electrolytes and calcium level. Morbid obesity, you need ECG plus or minus X-ray, and in case of hypercoagulability, you might need a coagulation testing, and LFT also may be required in obese patient. Malabsorption and poor nutrition, you need ECG, complete blood count, electrolyte, creatinine, glucose. Coming to specific drug therapy with digoxin, ECG abnormality. SVT is the most common thing which can happen with digitoxicity. So, you should have an ECG. Hyperkalemia and hypokalemia can influence digoxin management. So, you have to do an electrolyte and the digoxin level should be measured. Anticoagulant, you have to look at the count, total complete blood count and the coagulation status. Phenytoin, you have to look at the drug level. Phenobarbital, again drug level should be looked into. Diuretics, you have to look at the electrolyte. It might cause hypokalemia or hyponatremia. A lot of electrolyte disturbance can happen with diuretics. And creatinine, renal function should be checked in. From steroids, you have to look at the CBC and blood glucose level. They can cause hyperglycemia. Other chemotherapeutic agent, your complete blood count and renal status should be assessed. Aspirin, if bleeding is there, maybe you have to do the coagulation testing. Theophylline, you have to do a drug level. Need not be repeated during the preoperative evaluation of a healthy patient. By healthy patient, you mean ASA physical status 1 or 2. If similar study has been already performed within the 2 months preceding surgery and there has been no change in the patient medical status. So, patient healthy, ASA physical status 1 and 2, already pre-op testing is done within 2 months before surgery and there is no major change in patient medical status. In those cases, you need not ask for preoperative laboratory testing. Now, coming to the most common basic investigation which we do, CBC, hemoglobin and hematocrit. This is a basic investigation which you do in almost all cases. In the blood, plasma forms about 55% and your leukocyte and platelet forms around 1% and erythrocyte form around 44%. So, you establish the count of each blood vessels, RBCs, WBCs and platelet. And the most important investigation as an anesthesiologist for oxygen carrying capacity, we use hemoglobin and hematocrit. That is the basic investigation. Now, coming to complete blood count, hemoglobin and hematocrit. Proposed surgery, whether it is an high risk surgery or low risk surgery, associated potential loss and individualized patient care will determine whether a preoperative complete blood count is required or not. Typical indication for CBC, hemoglobin and hematocrit include history of increased bleeding, hematological disorder, chronic kidney disease, chronic liver disease, recent chemotherapy or radiation therapy which can cause myelosuppression, corticosteroid therapy, patient prone for infection, anticoagulant therapy, patient prone for bleeding, and poor nutritional status which causes anemia. These are all the typical indication for complete blood count. The NICE guidelines recommend routine CBC testing in ASA physical status 3 or 4 undergoing intermediate grade procedure and all patients undergoing major procedure. Now, coming to renal function test, this includes serum creatinine, blood urea nitrogen, your estimated glomerular filtration rate, uric acid and other optional parameter like your urine analysis or other tubular function parameter. This renal function assess glomerular filtration as well as tubular function. The primary aim for doing a renal function test is to assess the glomerular filtration as well as the tubular function. The primary clinical indication for renal failure includes diabetes mellitus and hypertension, both of which can lead to renal disease, cardiac disease, potential dehydration like vomiting, diarrhea, anorexia nervosa, bulimia, fluid overload state as happens in heart failure ascites, known renal disease, liver disease, relevant chemotherapy, cisplatin or carboplantin which can affect the renal function, and patient undergoing renal transplantation. The NICE guidelines recommend routine renal function testing in ASA physical status class 3 or 4 undergoing intermediate procedure and ASA physical status 2, 3 or 4 undergoing major procedure. So, any major procedure with ASA physical status 2, 3 or 4, you do a renal function test. If patients are deemed to be risk of perioperative acute kidney injury, you anticipate there are certain risk factors for acute kidney injury. If those factors are present, you can do that testing in ASA physical status 3 or 4 undergoing even minor procedure or ASA physical status 2 undergoing intermediate procedure. Coming to liver function test, this includes various enzymes, alanine transaminase, aspartate transaminase, alkaline phosphatase and gamma glutyl transferase. This happens with liver injury and this happens whenever there is a biliary obstruction. Apart from that, you have proteins. The normal protein is around 3 to 8 gram per deciliter. Albumin is the main component which forms around 4 to 6 gram per deciliter, and you have prothrombin and bilirubin. These are all the various liver function tests. Your enzyme, protein, prothrombin time and bilirubin. Liver function test is asked based on history of liver injury and variety of systemic examination finding. The primary indication for liver function test includes an history of hepatitis which can be viral, alcohol, drug induced or autoimmune hepatitis, jaundice, cirrhosis, portal hypertension, biliary disease, gallbladder disease, hepatotoxic drug exposure, tumor involvement of the liver and bleeding disorder. Now coming to coagulation testing, this includes bleeding time, PTT partial thromboplastin time, prothrombin time, thrombin time and fibrin degradation product. Coagulation testing is usually done in a known or suspected coagulopathy identified on the preoperative evaluation. The primary clinical indication for coagulation testing is a known bleeding disorder, hepatic disease and anticoagulant use. The NICE guidelines in 2016 considers coagulation testing should be done for ASA physical status 3 or 4, patient undergoing intermediate, major or complex surgical procedure and patient who is on anticoagulant medication or having liver disorder. Coming to urine analysis, this can be a complete urine analysis which is done in the lab and each component of the urine is examined, or a rapid urine analysis which is performed at the doctor's clinic using test strips. Here you can identify protein or sugar and those things, and a 24-hour collection urine which is done for urine sodium and other things. It is performed at home and the urine is collected over 24 hours and it gives a clear picture of both tubal as well as the glomerular function. There is no indication of routine preoperative urine analysis. The primary clinical indication for urine analysis include a suspected urinary tract infection or unexplained fever or chill. Pregnancy testing, it is very important. Now you can do a simple strip to know with the urine ECG level whether the pregnancy is present or not. Pregnancy testing are usually determined by hospital specific protocol. The clinical indication for pregnancy testing includes sexual activity, birth control use and the date of last menstrual period, your LMP. And another important thing is potential of the planned procedure arming the fetus. What are the various things which can affect the fetus? This includes a direct injury to the fetus, uterine surgery, reduction in blood flow, major cardiac or vascular surgery where your uterine blood flow can be altered and it can harm the fetus, exposure to teratogenic agents like X-ray done in the preoperative period. These are the cases where you have to do a pregnancy testing. 2012 ASA Practice Advisory for Pre-Anesthesia Evaluation suggests pregnancy testing to female patient of childbearing age when the result could alter the patient management. When doing pregnancy testing, informed consent should be obtained or there should be a full discussion of the risk, benefit and alternative related to the pregnancy testing. The NICE guidelines recommend that all women of childbearing potential be asked whether there is any possibility of being pregnant, and any woman who could be possibly pregnant should be made aware of the risk of anesthesia and surgery to the fetus. We have to document all discussion about whether or not to carry out pregnancy testing and to conduct pregnancy testing if patient consent if there is any doubt about pregnancy status. Now coming to sickle cell testing, which is usually done for sickle cell anemia. Here the patient may have normal hemoglobin or a sickle cell trait where there will be a combination of normal hemoglobin and sickle cell hemoglobin, or the patient will have a more severe sickle cell disease where you have only hemoglobin, yes, that is sickle cell hemoglobin only. Individuals at risk for sickle cell disease include those of African, Caribbean, Eastern Mediterranean and Middle Eastern region. These ethnic people are more prone for sickle cell anemia. Even in this high-risk population, routine preoperative screening have a very low yield, especially in region with newborn screening program for sickle cell disease. Consistent with this evidence, 2016 NICE guideline recommend against routine preoperative testing for sickle cell disease or sickle cell trait, but the reasonable approach is to consider testing in a previously untested patient who have an ethnic background and the clinical indicators for sickle cell is there. The clinical indicator includes patient related. It might be a family history of sickle cell anemia or symptoms of sickle cell disease like a vaso-occlusive crisis. Here the vaso-occlusion is caused by the RBC which becomes sickle cell, or surgery related clinical indicator, deliberate hypothermia which can cause the RBC to become sickle cell, cardiopulmonary bypass, intrathoracic and intra-abdominal procedure, orthopedic procedure with tourniquet use. These are the things which are clinical indicators for the RBC to become sickle cell. Now coming to another important investigation. Whenever patient has a cardiac disease, the first thing, or any systemic disease, the first thing we ask is an electrocardiogram. Apart from looking for heart rate and arrhythmias, you look at the PR interval, your QRS segment and your ST segment and QT interval. These are the various things you look at the preoperative electrocardiogram. Ideal indications for electrocardiogram is prior myocardial infarction, cardiac rhythm disturbances, ischemia, chamber hypertrophy and electrolyte disorder. When combined with clinical examination, the preoperative ECG may not provide additional prognostic information to identify individual at risk of postoperative cardiac complication. The primary clinical indications for preoperative ECG include an history of IHD, hypertension, diabetes mellitus, heart failure, chest pain, palpitation, abdominal valvular murmur, peripheral edema, syncope, dizziness, dyspnea on exertion, orthopnea, PND and cerebrovascular disorders. The 2014 European Society Anesthesia Guideline suggests preoperative ECG in patients who have risk factors for IHD or a suspicious symptom like chest pain or dyspnea if they are undergoing intermediate risk or high risk surgery, and ECG should be done in patients who are undergoing intermediate or high risk surgery who have a known IHD, significant arrhythmia, peripheral artery disease, cerebrovascular disease or other significant structural heart disease. Routine preoperative ECG is not recommended in asymptomatic patient without any cardiovascular disease or risk factor. The NICE guidelines recommend routine preoperative ECG in ASA physical status 3 or 4 undergoing intermediate grade procedure and ASA physical status 2, 3 or 4 undergoing major procedure. If patient has cardiovascular disease, chronic kidney disease or diabetes mellitus, testing also may be considered in ASA physical status 2 undergoing intermediate procedure. Now coming to the another important investigation which is usually done for the respiratory system, that is chest X-ray. It is most commonly performed and it provides lot of useful information in the perioperative period. But it does not provide prognostically important information for assessing the perioperative risk. Preoperative chest radiograph should not be ordered routinely but rather selectively based upon the abnormalities identified by the preoperative evaluation. Clinical indication for chest X-ray include advanced COPD, bullous lung disease, suspected pulmonary edema, suspected pneumonia, mediastinal mass and suspicious finding on physical examination, patient having trials or tracheal deviation.